Now our drugs are administered, so we've got to go through 4 stages. They go through absorption, distribution, coming throughout the body or in a certain area, metabolism, and then excretion. The study of these 4 stages and the actions of the drugs are pharmacokinetics. So as we get into that pharmacokinetics, we're looking at the onset of action, what is their peak time, and then the duration of action for most medications. And this is, once again, part of that looking at the slips as you get your medications or as you're looking it up on a drug formulary somewhere. The duration of action is generally related to the medication metabolism and elimination. As the amount of medication near cell receptors decreases, the clinical effects caused by the medication begin to decrease and normal function resumes. So this is where, as it's coming back down, your patient's like, I need some more. Some patients are very quick to tell you that. Some patients will be hours before they ever, or days before they ever ask for any more. Drug absorption. The passage of a substance through some surface of the body into body fluids and tissues is known as the absorption. Numerous variables affect drug absorption, including the nature of the absorbing surface, blood flow to the site of administration, solubility of the drug, your pH, so back to homeostasis, that acid-base balance, drug concentration, dosage form, route of administration, bioavailability, diffusion, osmosis, filtration. All of that takes effect in this, in your drug, how it's going to work on this patient. So I've got a general idea, but you may see it work a little different from person to person, and that's okay. Your drug distribution is going to pass freely and quickly out of the vascular space and into the interstitial fluid. Therefore, your blood flow to the area determines the amount of a drug reaching a particular body part. That's the reason in a CPR, if you can keep your IO in the humeral head as opposed to distal femur or distal your tibial tuberosity, then I've got a straight shot into the heart here, as opposed to having to do really good CPR to get it from my leg all the way up. So that distribution is a big piece of it. Or I just go ahead and get my IV. Now I realize that can sometimes be a challenge, or my EJ. So your biotransformation. Many drugs are inactive when administered and only become active once they have been absorbed and converted into an active form in the blood and by the target tissue. The chemical alteration that a substance undergoes in the body is known as biotransformation. The primary organ for biotransformation is the liver. If the liver is diseased, inactivated, or detoxification of drugs may be impaired. This will also increase elimination time of the drug from the body, possibly resulting in a toxic blood level. So your patient gets worse, not what we wanted to see. The liver performs synthetic reactions that yield inactive products or metabolites that can be secreted by the kidneys and non-synthetic reactions, which may result in products that are more active, charged inactivity, or less active. The drugs that are biotransformed to an inactive metabolite very quickly have limited effects on the body and must be administered frequently to continue the effect. Epinephrine, during a cardiac arrest, is an example of a drug that is rendered inactive very quickly and must be administered every 3 to 5 minutes as needed, or alternately as a continuous infusion. So our drug elimination, the excretion of the elimination of waste products from the body. Our drugs are eliminated in their original form or as metabolites. The organs of excretion include the kidneys via the urine, the intestines through the feces, the lungs through respiration, sweat through the salivary glands, and the mammary glands through breast milk. The rate of elimination varies with the amount of drug in the body and the underlying conditions of the excretion organs. During shock, when the kidneys are poorly perfused, drugs may remain in the circulation for much longer periods of time. That's the reason a lot of times when you take a patient in that's in cardiac arrest, you get a return of circulation. They're going to go ahead and put a Foley in, and that way they're going ahead and trying to get some of that elimination out. A patient's poor ability to eliminate a drug may result in accumulation of the drug, and subsequent doses are given, resulting in the toxic effects.